Well, hello and welcome to Lecture 20. This is Ward Stevens. And in this lecture, we are going to talk about the Patient Protection and Affordable Care Act of 2010, often referred to as the ACA or Obamacare. And I will provide a kind of a brief overview, and then we will go into detail on how the ACA addresses the issue of access. There are a good number of learning objectives for this lecture, so please take a moment to look at those so you know where we're heading within this lecture. All right, so in the last lecture, we talked about the ACA, the legislative process, the values that drove it, and noted that it was signed into law by President Obama on March 30th of 2010. And the bill generated a lot of regulations as it went through the regulatory process, which we also talked about. The picture there is Mitch McConnell, who is from the Senate Majority Leader, pointing to a stack of paper which he claims represents all the rules and regulations that were generated by the ACA. Now, we do know that there were about 897 documents that were created and approximately 10,000 to 30,000 pages. But that kind of depends upon how you count things. Some documents have very wide margins, some have very narrow margins, and depending upon how you print them, you can come up with different pages. But regardless, even if it's only 10,000 pages, that is a lot of regulations. Now, the Kaiser Family Foundation was monitoring the Patient Protection and Affordable Care Act and the progress that was being made over time. And as of 2015, a long time ago, there were 90 provisions that they were looking at. And a lot of those, maybe 26, went into effect in 2010, and others, as outlined in the bill, were implemented over time. So you don't have to know all 90 of those provisions. I hope I'm able to summarize them into something that is understandable. But when we look at the Affordable Care Act, we can really divide it into two phases. And this, layout of the ACA was not my idea. I had an opportunity to hear Donald Berwick, who was administrator for CMS at that time, give a keynote address to a meeting of osteopathic professionals. And he described it this way. And I think it's just a kind of a great way. If somebody asked you, explain the ACA to me, I'd go about it like this. He said that there were two phases. One was the coverage agenda, which probably, as the name suggests, has to do with health insurance coverage. And then phase two was the system improvement agenda. So in phase one, this is what Dr. Berwick said. He said that the coverage agenda's goal was to provide the coverage that people want and need. But he also added, and he pointed out, that this will not solve the problems because it is not sustainable. And when he talked about it not being sustainable, what did he mean by that? Well, so what did phase one, the coverage agenda, not address? Well, we know that it addressed access by removing financial barriers to healthcare by giving people the health insurance that people want and need. But it did nothing to address systems cost. I do like to note that it did help reduce the cost for individuals who did not have health care insurance, and just basically increase remove the cost barrier for them to get into the system. But when we look at it from a policy perspective, from a systems perspective, there's nothing in phase one that addresses cost. And it does not address quality directly either. So when we think about the triple aim, providing access is sort of related, but really has nothing to do with providing better care and at a better cost. So there was phase two, and according to Dr. Berwick, he called this the system improvement agenda. So we have the coverage agenda as phase one, the phase two is the systems improvement agenda. And its primary goal, according to Dr. Berwick, was to make the security achieved in phase one sustainable and to really achieve the triple aim of healthcare, which we've talked about: better care, better health at a better cost. And he went on to say, if we don't improve, we can't afford it. It is simple as that. Now, when we go back, and this is what we've gone over this before, is that there are two requirements for access. One is it has to be affordable, which means you either have to be really rich or have someone who you know who's really, really rich who will pay for you, or you have healthcare insurance. And for almost, I would say, pretty much the entire population, what really matters is having access to healthcare insurance. And then again, it also has to be available and accessible. You have to have the providers and the facilities and everything else. It needs to be, culturally appropriate and so on. And then you will also recall that health insurance is a key factor in accessing care. Now, we know that, again, not new information, but back in 2010, in the year that the ACA was signed into law, that about 16.3%, or about 50 million uninsured, there were about 50 million uninsured Americans, and that by 2021, that decreased to about 26 million, or about 7.9% of the population. So, kind of basically half the number of uninsured individuals, which is good. And a lot of that drop occurred between 2010 and 2015, and then we kind of see it's been pretty much the same since that period of time. So before we talk about some of the actions that were taken to provide coverage, I just want to introduce the idea. It's really not an idea; it's a real thing, known as essential health benefits. And as part of the ACA, all health plans have to offer services in different areas. And I should have put numbers on them so I'd know, but I believe there are 10. And the original plan was for the federal government to identify what would be included in all health plans. But that became a political nightmare, and this was shifted over to the states. But the advantage of essential health benefits is that if you are in the state of, say, Commonwealth of Virginia, that all the health plans provide the same benefits. So when you go shopping for care, you don't need to wonder whether or not one plan has something or another plan doesn't have it. They're supposed to have the same. So it makes it a lot easier to shop. But note that what is an essential health benefit in Virginia may be very different from a essential health benefit in the state of Louisiana. So moving on, how did the ACA, or what was included in phase one? Well, there were 5 things, and it's really good for you to know each of these. The first, which really had 2 components, was that insurance coverage must be provided to certain classes of individuals who are often not able to afford coverage. And one of those was individuals up to the age of 26 can stay on their parents' health insurance plan if their parents will let them do so. And if you may recall, when looking back at who the uninsured are, well, historically, and I don't believe that was on the slides that I shared, but there was a pretty large percentage prior to the ACA in that kind of that 18 to 26 age group. So allowing that provision, helped provide additional coverage for that group. And then the other one was eliminating pre-existing conditions as a reason not for an insurance company not to provide health insurance coverage. And we'll go into more detail on that in a few moments. But then there was what was known as the individual mandate. There's also an employer mandate. Then there were the health benefit exchanges or the marketplace. They kind of go by different terms over time. And then Medicaid expansion, which we've talked about some previously. So phase one, if you want to put it in a kind of in a picture, is the coverage or access agenda. It was to last from 2010 to 2014, and everything is actually supposed to be completed by 2014, but not everything. Everything happened, and we know that we still have approximately 10 states that have not expanded Medicaid. So let's go into a little bit more on each of the strategies. So the first one, as I mentioned, was to make provisions so that people who historically had a difficult time getting the insurance coverage to be able to do so. And so dependents can stay on their parents' plans up to the age of 26. What was kind of interesting was that was already in place in about half of the states. So it was not a new idea. This wasn't some wild strategy that was pulled out of the air. Now the eligibility of it actually though kind of changed over time. When the bill first came out, it seemed that if a child became married or they were eligible to enroll in their employer's health plans, that they would not be eligible to stay on their parents' plan. But things, I guess, changed at the regulatory level. And, even if a child is married, not living with their parents, if they're attending school, which actually I think makes sense for them to do it in that sense, even if they're not financially dependent on their parents, and even if they are eligible to enroll in their employer's health plan, they can still remain on their parents' plan. So what impact did this have? And these numbers are only through 2020, but looking back in time at 2010, about 27% of the individuals in this age group, and in 2010 the government measured in kind of age increments, and back then they measured from 18 to 24. And that changed over time, and actually the group got a little bit bigger, but the number of uninsured in this age group decreased from about 27% to 14%. So, and I would suspect that many of those who remain insured probably live with parents who do not have access to insurance, perhaps are unemployed. So the second part of the first strategy was to address the issue of pre-existing conditions. And as the name implies, a pre-existing condition is a health problem that existed before you apply for a health insurance policy or enroll in a new health plan. Examples I've listed here are heart disease, type 2 diabetes, or perhaps a previous injury. And historically, insurance companies, when they rated individuals, they would often look at the individual. So if someone had a history of heart disease, the premiums that they would charge would be really, really high, and actually so high that the individual probably could not afford to obtain health insurance in a time when they probably really needed it. So the second strategy really was kind of phased in about 6 months after the passage of the bill in September of 2010. Children with pre-existing conditions could not be denied coverage. And this was implemented for adults in January of 2014. But a question might be as well, so how bad or significant was the issue of pre-existing conditions? How many people were not able to obtain health insurance because of bad genetics or bad luck or whatever? They estimated that about 1 in 5 non-elderly individuals had a pre-existing condition, which equated to about 25 million people. And then they also did an estimate on what would happen if those who had a pre-existing condition became unemployed when their original employer was, large, and they had to become self-employed and had to go get coverage themselves. And they put the number at 82 million. And I do want to mention, this is not a testable item, But one of the things that was put into place as part of HIPAA, which I think you've probably heard of and has to deal with protecting health information for individuals, is that HIPAA also prevented employer health plans from excluding somebody because of a pre-existing condition. So if a person with a pre-existing condition went to work for General Electric or Ford Motor Company, their health insurance plan had to accept them regardless of any pre-existing conditions. So really what this did was take that, what had already been done in HIPAA, and applied it to the individual or small employer health insurance plans. So that was strategy one. So what is strategy two? Strategy two, it was the individual mandate, which became effective in 2014 and basically said that all individuals must have coverage, and if not, there would be a fine or tax consequences for being non-compliant. And back in 2018, and I'll stop at 2018 because of something that occurred in 2017, is that the penalty equaled about 2.5% of the yearly household income, with a maximum of a total premium of a bronze health plan. And we'll learn about bronze health plans here shortly. But what that would kind of equate to is about $695 per adult, and then for children about half that. But during the administration of President Trump, the Congress passed the Tax Cuts and Jobs Act of 2017, and it actually removed the language. I'm sorry, it did not remove the language. It left the language for the penalty, but removed the amounts. So the law requires you to have coverage. However, there's no penalty for not doing so. And if I remember correctly, with the health policy survey for this class, y'all didn't think there should be a penalty. So we don't have one anymore. So yeah, oh there it is. Now I don't think this is actually your class. This is the year before, but the results are pretty much the same from year to year. Now the Congressional Budget Office, when legislation is introduced, it's the job of the Congressional Budget Office to estimate its impact. And when it came to the elimination of the tax penalty with the individual mandate, they said that it would reduce federal expenditures by about $338 billion over 10 years. And they also added that it could result in 4 million more uninsured individuals by 2019, and also increase premiums for health insurance in the individual market as well as the marketplaces. And again, we'll talk about marketplaces in a bit. So what actually happened? Well, when we look at the number of uninsured, it dropped from about a million between 2017 when the bill was passed to 2019 to 27.5 million, but it did increase by about 500,000 by 2020. But the prediction that it would increase the number of uninsured by $4 million was a little off. So oftentimes, I guess, with anybody who's estimating, sometimes they're right and sometimes they are not so right. And in this instance, they kind of missed the mark, I think, significantly. And then the other thing that they estimated was that premiums would increase. And these are just numbers that were pulled based on a 27-year-old single non-smoker. And during this period of time, the employer-based coverage for family coverage increased by about 5%. Employer-based single coverage rose about 3%, and an average premium increase in the marketplace was up about $201. But between 2019 and 2021, premiums declined for the third year in the row in the marketplace. So not as big an impact, I think, on premiums as the Congressional Budget Office thought at that point in time. So the individual mandate is still the law of the land, but there's no penalty for it, and its impact doesn't seem to have been as great as was originally projected. So the third strategy was the employer mandate. And the employer mandate, as the name suggests, requires employers, but only those with 50 or more full-time employees, to have insurance or to offer them insurance. And a full-time employee is defined as one that works at least 30 hours per week. And the plan must provide what is known as a minimum coverage that equals 60% of actuarial value. And we'll talk about actuarial value on the next slide. But the employer mandate, when this came out, did have a negative impact on people that I knew, people who have been in this program, not on the online side because we didn't have an online program back at that period of time. But I heard from students, for example, who maybe working 40 hours a week or 32 hours a week or something like that. And when the law came into effect, all of a sudden now they were working 28 hours a week, which meant that their employer did not have to provide coverage. So there was some negative impact from that. In fact, one of the employees actually worked for a city government in the Commonwealth of Virginia as a paramedic, and actually lost healthcare coverage because of the employer mandate. So again, that's just kind of just a reminder that when certain things are put into place, that we understand the consequence, but it can also have some unintended consequences as well. But let's get back to actuarial value. And this is kind of a long definition, but it's basically the percentage of the total average cost for covered benefits that a plan will cover. And I've written a kind of an example in there. And if the plan that you have has an actuarial value of 70%, that means on average that you would be responsible for 30% of the cost of all covered benefits, and the health insurance plan would pay for the other 70%. Things can change a bit based on your needs and the terms of your health insurance policy. However, that's kind of the general definition. So all healthcare plans out there that are offered by employers have to provide at least 60% actuarial value. So the other thing kind of related to that is that the employer also has to provide affordable coverage, which means, again, that the actuarial value has to be greater than or equal to 60%, but the employee's contribution to the premium cannot be more than 9.65% of the household income. So, those on the employees in a company who are maybe on the lower income level within the organization may have the amount that they have to pay for the premium capped would be capped at that level. So that is what affordable employer coverage is. Now, the penalties for not meeting this are, I don't know if they're that severe, but penalties will apply if any of the employees becomes eligible to receive subsidies in the marketplace and exchanges, which we will talk about. And this penalty equals kind of the lesser of $3,480 if there are any subsidized employees, or roughly $2,200 per full-time employee minus the first 30. Now, please don't try to memorize that that penalty. In fact, don't worry about the next couple of slides. I'll try to remember to tell you when to worry again. But the reason why I want to share this is, again, is kind of looking at what the impact of some of the things that are out there. And let's just pretend that we have an employer with 52 employees. They're all working greater than 30 hours per week. They have half on a family plan, half on an individual plan. And that this employer, he's cheap. He's only paying providing a plan that meets the 60% of the actuarial value, and just kind of going down to the total employer cost would be roughly $483,600. And his penalty for not providing coverage would equal about $180,960. And when you look at the difference between what the cost would be and what the penalty would be, in this instance, you would see that the employer would save over $300,000. Now, having said that, I think there would be other penalties to the employer as well. One is they probably would have a really hard time hiring employees. But I think that looking at it in the way it was designed, is that I understand the need to penalize if the employer isn't going to participate. However, the penalties may not have been severe enough to make certain employers do so. But I think the reality of the market is that employers are going to provide coverage in most instances. So let's move on to the fourth strategy, and that's the healthcare marketplace, often referred to as the health insurance exchange. And a kind of a way to look at it, it's kind of like Expedia or Kayak for healthcare. But difference is that when you're going to buy a hotel room, not all hotel rooms are the same. But within the healthcare marketplace, there are 4 types of plans, and they all offer essential health benefits. And really, the only difference between the plans is the actuarial value. Well, it's not necessarily the only difference, because different plans may include different providers. They may have different groups of physicians that participate. So you have to look at that as well. But the actuarial values are kind of distinguished by metals. And bronze, actuarial value is 60%. Silver 70%, gold plan 80%, and then platinum plans are at 90%. Most people will buy, 70% seems to be the most popular plan. So the exchanges do have eligibility requirements. The income has to be between 138% to 400% of the FPL in states that expanded Medicaid, and from 100% to 400% in states that did not expand. If no affordable coverage is available from an employer, that gives an individual, makes an individual eligible, and then they cannot be to be eligible, you can't be eligible for Medicaid, Medicare, CHIP, or other public assistance programs. And you also have to be a U.S. citizen, and if married, file taxes jointly. But I think the primary thing to remember about the exchanges is that it's based on income, and is primarily for those who are make too much for Medicaid, up to about 400%, up to 400% of the federal poverty level. Now, the exchanges also provide a catastrophic plan. This was not originally part of the ACA, but they were essentially plans with pretty low premiums, which means they're going to have what? If your premium is low, what's probably going to be high? And what's going to be high is cost sharing. Your deductible is probably going to be several $1,000s versus potentially a couple of $100 depending upon your employer if that's where you're getting your insurance. Cost sharing might be higher as well. But another limitation of it is you have to be under 30 years of age, though there are also some hardship exemptions that can apply as well. And you can purchase them in the exchanges, the marketplace, but you can also get them out of the exchanges through a private, health insurance broker as well. So what happens if you purchase insurance through the exchanges is that the individual or whoever's paying the premium. So we know the eligibility requirements for the health insurance exchanges marketplace, but what's the benefit? Well, the benefit is that if you're eligible and you buy a plan through the exchange that meets essential health benefits, the amount of your income that can be utilized to pay the premium has a maximum limit. So if someone is between 100 to 133% of the federal poverty level, they can't spend more than 2% of their income to pay for health insurance. And then as it goes up, you see more income. You can, more of the cost sharing limit increases. And so if you go up to 300 to 400% of the FPL, it's 9.5% of income is the most that the eligible individual family would have to pay for healthcare insurance. So we've talked about the federal poverty level before, and you just kind of see the levels as they were back in 2021. So here's an example of how it would work. If you have a family of four at 150% of the FPL, and this again is a 2021 example, their income could not exceed $39,750. And then the annual silver premium, and this was drawn from an exchange at that point in time, was about $26,400. And given that their income is $39,750, 2% of that is $795, which means that there would be a tax credit equal to roughly $26,000 that would be paid to the beneficiary or the insurer. And so usually somebody that making $39,750 isn't going to pay $25,000. It would go back to the insurer. So it doesn't go back to the individual. It basically goes to the entity that is, or individual who is paying the premium. So pretty good commercial coverage at a low premium cost for a family in that situation. So let's take that same family and increase their income to 400% of the federal poverty level. And you'll see that their income would be roughly $106,000. The annual premium is the same, and the maximum that they would have to pay, 9.5% of $106,000, is roughly $10,070. So there would be a substantial tax credit for that as well, roughly $16,000, who is paid to the beneficiary or the insurer. So a pretty healthy subsidy of healthcare premiums for people within those income groups. Now, there are also cost sharing subsidies that impact actuarial values. So if someone is between 100 and 250% of the federal poverty level, the cost of their deductibles and co-payments and co-insurance will be reduced. However, this only applies to silver plans. So if you're between there, what are the chances of you being able to afford a gold or platinum plan? Pretty slim. But if they could, they wouldn't receive any subsidies for cost sharing. And this only, again, just applies to the silver plans, but the impact is that this can increase the actuarial value to a gold or platinum level, where the insurance company and the taxpayer subsidies are covering somewhere between 80 to 90% of the cost. Now, this has been a kind of a controversial issue. There was a lawsuit to end the cost sharing subsidies because, and the basis was is that the HHS did not have congressional approval to provide the funds. And this did go to the Supreme Court back in 2021, and the Supreme Court ruled that insurers are entitled to the cost sharing subsidies. So the patient doesn't have to pay them, and the insurance company gets, I guess, reimbursed just as if they had been paid. So the results for the exchanges are, pretty significant. We have about 3% of the U.S. population that has enrolled in them as of 2021, roughly 12,700,000 people, which is about 50% more than the initial enrollment, which occurred back in 2014. Now there are different types of health insurance markets based on who operates them. And you can see in the green that those represent states where the marketplace is actually operated by the federal government. And then in some of the other states, the states are running them, or there's a kind of a partnership between the state and federal platforms. But this kind of led to some challenges within the federal courts. And there was a case that Halbig versus Burwell. Ms. Burwell was the Secretary of the Department of Health and Human Services. So she was the one who's named in the suit, but it's really the federal government. But the way the law was written, it states that tax credits could only be provided to state-run exchanges, and therefore tax credits to federal-run exchanges are inconsistent with the law. And on July 22nd at 2014 at 10 a.m., the District Court of Appeals ruled that federally established exchanges can issue tax credits. All right, well, you would think that would put everything to rest, but no. Down in Richmond, Virginia, it's like 2 hours later, by lunchtime, the Fourth Circuit Court of Appeals in Richmond ruled unanimously that the federal exchanges cannot issue tax credits. So when you have two federal courts that are disagreeing, probably what's going to happen, it goes to the Supreme Court. And so after that, the Supreme Court ruled that the federally operated exchanges could provide tax credits, as the disputed language, they said, was ambiguous, but it should be interpreted in a manner consistent with the rest of the ACA. So the subsidies for the exchanges survived. So well, this sounds great, you say. How do I sign up? Well, the way to sign up is you go to healthcare.gov, and it actually has a pretty user-friendly website, but it provides a way to determine what you are actually eligible for. Not only does it share with you the different the subsidies that you might receive by purchasing a private health insurance plan on the exchange, but can also determine whether or not you are eligible for Medicaid and CHIP. There are established enrollment periods which you have to, times that you have to enroll in, which are listed there. I don't believe those have changed. So there are, if you don't meet that period for whatever reason, there are, if certain life events have occurred, such as perhaps getting married or having a child or something like that, you can enroll at other times. And this is just a slide with the link to that site. So the final and fifth strategy was Medicaid expansion. And as states were eligible to expand Medicaid in January of 2014, And you can see in this slide from the Kaiser Family Foundation that just comparing the states that did expand at that point in time to those that did not, that there was a bigger drop, about from 18.4% to 15.7% in the states that expanded, but only a slight drop from 22.7% to 21.5% in the states that did not expand. As I previously noted, Medicaid expansion was available in 2014. And at that time, like 26 states expanded. And it was eligible for adults up to 138% of the poverty level. And it's also important to note that the Medicaid programs had to offer the same essential health benefits that were available in the exchanges. And in order to encourage the states to expand Medicaid, the federal government, or according to the law, the federal government would provide matching dollars for those who newly enrolled in the Medicaid program. So from 2014 to 2016, the matching rate was 100%. So if a new person came on board and their cost was $15,000, then the federal government would provide $15,000. And that reduced over time, I think, in order to, well, one, reduce the federal responsibility, but also to encourage states to engage in the program earlier rather than later. But there were numerous challenges to the Medicaid expansion. And, the thing about the bill is that it required the states to participate in the Medicaid expansion or lose all federal funding for their Medicaid program. And the states were concerned that they were being coerced to adopt Medicaid and would be an infringement on state rights. And personally, I think I kind of agree. If the federal government can just withdraw their funding from everything, they can pretty much tell you what to do, whatever the issue is. And then the ACA, they claimed, was invalid because it did not include what is known as a severability clause. And what a severability clause says that if one part of a law becomes invalid, the rest of the law remains in force. And whoever put together the final documents did not include it there. So it was challenged on the basis that it did not meet this requirement. You will often see severability language in physician contracts, and it'll say something like, if laws change and this we can no longer do this, well, we'll forget that part of it, but the rest of the contract is enforceable. So this went all the way up to the Supreme Court, and as I noted before, the ACA permitted the federal government to withdraw all federal funding in non-expansion states. The Supreme Court said this is coercive, but they did say that expansion was permissible if the denial of funding was removed. And so that occurred. And it also ruled that the entire law would not be thrown out because one section was deemed to be illegal. So the law had some implications. One is that all remaining provisions of the ACA could be legally implemented. And so far, I think currently there are about 10 states that have not expanded. And these states, primarily located in the South, are home to the highest percentage of uninsured. And then it also created what is known as and another implication is the ruling created what's known as the coverage gap. So these are kind of average numbers, and they're back from a few years ago, but many states do not provide Medicaid coverage up to 100% of the federal poverty level. And based on this information, as of January of 2020, pretty much it was 41% of the federal poverty level. So there were people, below 41% of the federal poverty level who are eligible for Medicaid, but in order to be eligible for the marketplace, they would have to be at 100% of the federal poverty level or higher. So there is a group of people previously estimated at 2 million who have no option for coverage. Their option is you hope you can go find an employer that provides affordable coverage that you can actually afford. So the coverage gap has an impact on those making more than 41% of the FPL and less than 100% of the FPL. So where does the coverage gap exist? When we look at it, from a state and regional perspective, we can see that the Texas, Florida, Georgia, North Carolina. Well, North Carolina recently, passed or approved Medicaid expansion, so they'll drop out of that. But concentrated in a few states, and most of them are in the South, the areas where VCOM serves, and when there's a tremendous need for healthcare. So what has happened with Medicaid over time? The Medicaid enrollment increased by 43%, to about 81 million individuals by February 2021, compared to prior to the Affordable Care Act. And actually during the COVID situation, that number increased even more as more people became eligible. And then uncompensated care cost at hospitals has also decreased by about $6.2 billion between 2013 and 2015. And when if you think back to the presentation on nonprofit versus for-profit, a lot of discussion about charity care that has to be provided. Well, there's a lot less charity care that needs to be provided in the expansion states. So, I think we need to consider that as we determine or look at the value of those tax exemptions that are still being provided. But looking at HCA, this greatly benefited the for-profit hospitals as well. The HCA actually has a lot of hospitals in places like Florida and Texas, but they're also in states that did expand, and they saw about a 58% reduction in uncompensated care. And HCA, I think, as I pointed out before, is the largest provider of hospital services in the United States outside of the Veterans Administration system. So you've seen this slide before, but the current status of Medicaid expansion decisions, we still have 10 states. And again, you can see where they are primarily located. Now, there are a lot of arguments against Medicaid expansion. One is that states don't want to be coerced to adopt Medicaid. They did argue unsuccessfully that the severability language was not included and should be thrown out. There have also been arguments that Medicaid is far from a perfect system, and that states need to be able to modify the system prior to implementation. Medicaid's been around since 1965. There haven't been a ton of improvements to it. So that's a somewhat logical argument, but I think the states would rather. Well, I don't know what the states want to do. But the other thing for many states, particularly in the South, whose budgets are much smaller than those in other parts of the country, is that the added expense to the budgets, which began in 2016, would threaten the ability of the states to provide other essential programs. And then kind of a really big question, and an important one, is how is the government going to pay for it? Essentially, and basically, I think that's a good question, because we have to be able to pay for things, and we haven't seen a whole lot yet in the bill that's really going to help to control healthcare cost. But there are also arguments for expansion. One is that if the state doesn't expand, the tax dollars that that state does send to Washington, D.C. is going to end up going to other states. And then, I think a good argument is just the financial impact as dollars are spent. When somebody has health insurance coverage, they go to healthcare facility, the money comes in, it is received by the hospital, by the employees, who then go spend that money within the economy, and also kind of related to job creation. Um, uh, Also if you don't expand, it's a loss of funding to hospitals that serve many non-paying or poor paying patients. There's a lot of argument that rural hospitals would really benefit, and it would also, I think probably one of the better arguments is it would improve health for those currently uninsured because they would feel they would be able to access healthcare services. Now we're getting close to the end. I know this has been long, but we had those 5 strategies. But also just want to note some changes to private insurance that occurred in 4 areas. So we're going to talk about each of those. So one is that health insurance plans historically had annual or lifetime limits. And so over time, these annual and lifetime limits were eliminated um, for most plans. So, or basically for all plans, beginning on in January of 2014. So historically, you could buy a health insurance plan, and maybe you had a maximum annual limit of say $500,000, and if you had $600,000 of bills, that $100,000 was on you. So that has been removed for essential health benefits. And for example, if you go over the limits because you have cosmetic surgery that's not for a medical purpose or can't be justified that way, it's probably not identified as essential health service. You would have to pay for that. You'd have to pay for it probably anyway. And then another thing that was banned was retroactively canceling health insurance coverage, except for fraud. There were cases out there where, perhaps expensive cases, where the insurance company would just come in and say, "Oh, we're not going to cover you anymore," after the healthcare services had only been delivered or had been delivered. So what do? I mean, that would be a mess, and most individuals don't have the ability to, go after a healthcare plan. And then health plans must also establish an appeals process for coverage determination. So if they do deny care for something, or they do deny initial coverage for someone, there has to be a documented process that an individual can go through to challenge that decision. Another thing that changed was, or was implemented, was this thing called the minimum loss ratio, and or the MLR. And what it is that, or what it says is that the health insurance company who's collecting the premiums has to spend a certain amount of the premium that it collects on health services and quality. Now, I didn't put quality in there at the end of that line, but I should have. So if the health insurance company collects $100,000 in premiums in the large group market, then they have to spend at least 85% of that, $85,000, on actual care, actually paying providers, or on quality initiatives. And in the small group individual market, that is only 80%. And the remaining, well, they get to keep that for administration, for marketing, for profit. So it does, I think that 15% is probably pretty generous. The insurance companies are making good money, but it does kind of put a floor on the profits that they can make. And what happens if they don't hit those ratios? Well, the federal government looks at looks at these things on a basically a 3-year rolling average, and if the medical loss ratio is not met, then rebates are paid back to the individuals or the companies that are paying the premiums. And in 2021, the rebates were about $2.1 billion. So that is a lot of money. But on the individual market, small group market, and large group market, you can see the amounts that are listed there. Is that, if a premium's $10,000 and they were off by $299, that's really not that much. So, the insurance company, I think, it appears to me, have been estimating pretty well. So that concludes this long presentation. I know there's a lot of information in it, and if you have any questions, I hope